for having that amount of employees.
And what's your annual budget?
I don't have that information with me at the moment.
Okay, if you could potentially ask Maria and then get that information to us, you can either email it to the research associate for us or to Rita, and she'll get it to the commissioners. Any other commissioners with questions? Please, Commissioner Ho.
Thank you, Mr. Chair. Thank you very much for being here, and thank you for the work that you have done for the past 20 years. It's nice to see census along with as a topic that you address along with illness prevention and medical access. My question is, if there's a specific neighborhood in the city of Los Angeles who would like to be involved, to participate, how does that occur? What's the process there?
Well, the process is first identify the need, and most of the times by working in the community, by knowing the members, they identify the need, and then it's when we respond, or the promotores respond, or the organization respond and ask for integrating the promotores model.
Thank you.
Thank you. I noticed in mental health is one of the issues that you folks deal with.
Commissioner Historic, can you speak into the microphone, please?
I thought I was, but anyway, I'm
Just bring it closer, Commissioner.
trying.
There you go.
There we go, okay. In the issues of mental health, if the folks that you're working with, the patients, if you will, are your folks able to handle a break with reality if someone has a mental health crisis? Do they attempt to intervene?
Well, the promotores are trained in different areas and different subjects. There is promotores that work in mental health, and they've been well trained to intervene in different cases. I myself have been providing suicide prevention, and by having the right knowledge and the right information and resources, they're very effective in intervening in the community. And there is a lot of different programs or mental health programs in different parts of California.
Okay, thank you. There's so many emergent, where we hear all about police response and so on. I'm just wondering if these folks could, in some sense, preclude the necessity for sending police and so on to an emergency.
Yeah, definitely a promoter will be needed in those responses, because there are the ones that will truly understand what's going on with the family or what is going on with the individuals and make that bridge. Because at those moments, we don't trust sometimes the services, but having a promoter next to us will help a lot.
Well, that was what I was thinking, the crisis in a family situation, if they could be familiar with that. Thank you.
You're welcome.
Dr. Chava?
In the data you guys collected in determining the effectiveness of the Promotora program, what are the major trends you've seen over the past 20 years for improvement, knowing that it's been effective?
Well, there is different ways to see that the promoter has been effective. We see that the community get involved, so the growing of the programs, the involvement of the community has been growing a lot. But also, when we talk about adherence to medication or to manage what is the health results when a promoter is involved, we can see the difference. In the pandemic, when nobody can reach out to the communities or organizations were trying to provide tests or vaccines to the community, there were not that much positive response. But when the promoter get involved, you can see the difference of serving 20, 30 people in the community to 200, 250.
Dr.
You guys
Lemos?
had-
Oh, sorry.
Oh, we have
Do you have another question?
Just as following up, do you have potentially on a website or a report, like a comprehensive analysis of these improvement trends?
We have different reports in our website that talks about the effectiveness of the model.
Thank you.
Dr. Lemos?
Well, again, thank you for this wonderful presentation. Part of the reason why I invited all of you today to present is to really think about the sustainability in your specific organization. So knowing your work, I'm interested how difficult it has been or the changing needs, because a lot of that COVID money, right? A lot of COVID money really funded a lot of projects for a couple of years. So I'm interested in knowing like what would help your promotora programs to be sustainable in the long term, right? Because a lot of these projects that you get from Medi-Cal or from different organizations are just short, 1 year, 6 months, and they're project-based, right? You complete the project and then you have to continuously look for funding. So what are ways that the city can help you in terms of funding your project or your programs?
Thank you for that question, Ms. Lemos. And yes, it's been a challenge for promotores to be integrated in the workforce. A lot of the promotores at the beginning of the work were perceived as a volunteer work. And through the years and knowing the effectiveness of the promoter work, they've been incorporating in different organizations as an employees. But sometimes, as you said, there depends on the grant or depends in the funds that are available for those programs. So promotores most of the time have a job opportunity for certain time, like 1 year, 2 years, and then when the funds are not available, they're again without an employment. So something that we are advocating is for promotores to be integrated in the workforce as a permanent employees with benefits, because they go to the community and try to help them to get benefits, to get access to health service when they don't have access to health service. And we have a report about the economic impact of promotores in our website that it says that even though they are the first the first response people in that community, most of them are living under the wage. So financial support or funds that will fund promotores not only in the medical area, but as for the community-based organizations that are the organizations that collaborate, that integrate this model, will be so important.
Yes, I think that out of COVID, we saw that everyone wanted promotores, right? From the census to, the Department of Public Health, but we haven't seen that continuity, right? So that's definitely something that we're very interested in seeing how we can partner and how we can be your advocates. My second question is, a couple of years ago, Medi-Cal made community health workers prevention services as a fee-for-service. Is Visión y Compromiso taking advantage of that service, a fee-for-service?
We are in the process to implementing that reimbursement for Medi-Cal for some of our promotores. That's one way to support promotores, but if you are familiar with the medical system, the structures are very complex. The reimbursement, you will need to break it down to so many different steps that the amount of money that rely for promotores is very minimum, but definitely something that Visión y Compromiso will implement. We are on those stages to implement it, and also help other organizations by sharing our knowledge. How can they also take advantage of this benefit?
Thank you.
Commissioner Cato?
Yeah, thank you so much, Elma, for your presentation. You said there's volunteers and people that are employed. About what percentage are volunteers?
I will not be able to give you an exact percentages of how many are volunteers and how many are employees at this by the top of my head, but not many promotores have regular employees with the organization. So I will say the majority of promotores is still on their volunteer programs or as getting a recognition by getting a stipend or getting a gift card by the services that they provide, but not a full employment with benefits.
And also you were saying how if there's a need in the community, they could request the promotora to go and help out. Is it based on like their expertise, or is it based on proximity? Because it's so important to build that sense of network community to make it successful, right? You need familiarity. If you have someone that knows the people, it might go faster. How does that work?
Well, it's been developing through the years. The most effective way to implement the program is by the promoter being in the community. Because even though if the promoter don't have any specific expertise in an area, they will know another promoter that is an expertise and will make that connection for the family.
Okay, thank you.
Any other commissioners? No? Second bite at the apple, anybody? If not, thank you very much. Please stay there, because maybe after the conversation, we'll have more questions for you. I'd like to introduce, I think, Chad Monk, who's the Senior Vice President, Programs and Public Policy for the National Health Foundation. Mr. Monk, thank you for taking time out to come to educate us.
Thank you. I just want to say, is this on? Sorry.
Yes,
Oh, okay.
pull it closer to you.
Is that better?
You can drag it.
It's almost in my mouth.
There you go.
Okay. I just want to first thank you, and I'm really glad that I'm following Alma in this presentation, because we actually have hired promotoras from your organization. They love your support that you provide them, and they're always asking me every year, can we go to the conference? Can we go to this training? So this organization provides a lot of support to people in this field, and myself and my organization, so thank you for that. Yeah, so Chad Monk, Senior Vice President of Programs and Public Policy with National Health Foundation. Commissioner Cato, despite the name, we are based in Los Angeles. We were started in Los Angeles, and we are not a grant-giving organization. We are a direct service organization. People 50 years ago had big aspirations, so apologize about that. Our mission as an organization is to improve the health of under-resourced communities. Oh, next slide, please. There it goes. And our vision is that all people, regardless of who they are or where they live, can achieve their highest level of health. So it is a public health organization. We are a social service organization. And again, we're headquartered and started right here in Los Angeles. We were established in 1973 by the Hospital Association of Southern California to do research, initially do research on healthcare and hospital outcomes in the community setting. As the field of public health evolved, and we really learned of how your health is more driven by the environments you live in and the supports you have, the organization evolved as well. We have been operating recuperative care programs since 2010. Recuperative care is interim housing for people experiencing homelessness as they are recuperating from an illness or injury after a hospital stay. So hospitals and health plans refer individuals into our housing facilities. Our other big bucket of programs, which I'm here to talk about today, is our community health initiatives. So if we could go to the next slide. So for our community health initiatives, we have youth engagement and empowerment programs, community-led built environment improvements, and what I'm going to talk about today is our food access initiatives and nutrition programs. Next slide. Before I get into that, though, I do want to just state that our work is grounded in building coalitions and leading community, or creating with communities leader groups. We strongly believe to create these programs to address deep-rooted health issues, you have to work with people with lived experience, who's living the issues, right? And so we've done this with some pretty notable success in two neighborhoods in Los Angeles, Pico Union and South LA. In Pico Union, we do have a group of 40 residents who are primarily volunteers, but are trained promotoras, most of them. They're in their 5th year of organizing and operating programs in the neighborhood. They meet at one of our recuperative care facilities, so they do integrate programs with our unhoused neighbors as well. But some of their successes, they've implemented a 5-year street improvement and beautification plan with the Department of Public Works. If you go over to the specific neighborhood they're working in, it's 18th Street and Union. A lot of street changes happening over there because of promotoras volunteering their hours to improve their own community. They've established a community garden, and we have an annual calendar of events that packs the community with resource infusion. They host health fairs, they host vaccine clinics, that's actually how I know Commissioner Lemus, and food distribution. So they really are improving the health of their neighbors there in that community. One other example is in South LA, where we've worked with youth. We used the youth participatory research model to build the capacity of young people so that they could change the environments in their community to increase health and healthy living. Some examples of their successes, some market makeovers, you probably have seen those, the little corner stores, as they encourage and work with market owners to bring in fresh produce to their neighborhood. And they've also helped establish the Park Equity Alliance, which it was a county effort, but it has secured millions of dollars for park poor neighborhoods in Los Angeles. Next slide, please. I think that went the wrong way. There we go. So today, the primary program I'm here to talk about is NHF's CalFresh Connection program. The purpose of that program is to tackle food insecurity among under-resourced communities in Los Angeles by connecting households to CalFresh benefits and strengthening their access to affordable, healthy food. So how do we do that? So NHF hires and trains local promotores de salud, or promotores, community health workers, they have a lot of names, to engage with targeted communities across the city and the county through community events, food distributions. They're invited to workshops, any type of outreach. Sometimes they just do their own grassroots. They'll go to churches and schools and things like that. They will then schedule appointments with individuals that they connect with to come to where they're stationed around the community. It's FQHCs, community resource centers, senior centers, parks, and they will schedule appointments for people to come in and get assistance with signing up for CalFresh. If you are not aware, CalFresh is what was formerly known as food stamps or EBT cards. It's now called CalFresh Food Benefits. So depending on the level of need, when an individual comes in for that assistance, the promotor will either help the client prep the application materials and then send them home if they feel capable of doing it on their own, or they will actually sit there with the individual and go through the application. And in some instances, while we don't encourage it, they will actually fill out the application for an individual, especially if there's some disability barriers there. Okay, and sorry, not yet. Well, a couple more things on that last slide. So the thing that this program does that I think is unique and special and really started because we have promotores is that they don't just help with the application process, but they actually provide 6 months of case management to those households or individuals that come in for application assistance. And so within that 6 months, they're monitoring their food insecurity, assisting individuals with how to use their EBT card if it gets stolen or if it's lost, where they could use it, and other programs that plug in. So they're very knowledgeable. Our staff are very knowledgeable about other things and activities around in the community where they could like almost layer this assistance on. So one example would be Market Match. So when one of our promotores in South LA, they know all the farmers markets, the days are there, and which vendors will use Market Match and how they could layer more money onto their EBT benefits, basically. Next slide. Other direction. There we go. This slide doesn't have a ton of information on it because I did provide everyone with our small best practices document, which we put together when we were launching the program. And a lot of this actually comes from Visión Compromiso, so thank you again for that. And so I'll refer to this when talking here, but we use this model and we've hired promotores because it was proven by research and it was really proven by our pilot and our project outcomes. And so I'll do this quickly because we just had a wonderful presentation on that, but I want to cover what a promotor is, the 7 core roles, and the model. So for NHF purposes, the definition of what a promotor is they're an individual who comes from and are part of the communities that they serve. They share a language and have common culture, values, and knowledge of their community resources. And we although most of our staff come trained, our model does have 7 core roles of a promotor, and those, I'll read them quickly, are cultural mediation between communities and the social service system. So in our case with CalFresh Connection, it is DPSS. They provide a culturally appropriate and accessible health education. So sometimes they're not doing applications, they are just providing education to the community, whether in group settings or individuals. They assure people get the services they need, and so that's actual application assistance. They provide informal counseling and social support. And I do just want to clarify, unless someone is trained as a clinical professional, they do not provide that level of support, but they are there to help navigate that type of assistance. They're advocating for individuals and communities within the social service systems. They provide direct services and administer health screenings. We heard before, like the COVID test, and in our instance, which I'll talk about in a couple of slides, a food insecurity screening and assessment for households. And then they build individual and community capacity. And what that looks like oftentimes is, while they might be working with one individual, let's say a senior citizen who's on disability but now qualifies for CalFresh, they will encourage family members to come along into the application process. So in 6 months or a year, when someone's application is due for renewal, if they still need it, the whole household and the people around this individual also have the capacity to help. And so that's one of their core roles. I'm going to skip this next part because we already had the model covered, but NHF uses the model that was shared earlier, which is building relationships, sharing of information, and creating opportunities for communities to get resources. We go through, our CalFresh promotors go through each of those steps where, as an organization, we gave them time to share and come in with the relationships they have and build those even deeper. They weren't hired and right off the bat say, enroll 100 people this month. They had to have the time to actually build those deep relationships, especially if that's what we were hiring them for. Then they take their time to share resources. Obviously, ours is focused on food insecurity and CalFresh, and then again, creating those opportunities for community participation, building up the capacity of other individuals in the community to act as almost promotors as well. And the one other thing in here I want to mention, I'm not going to go through this whole thing, but I do want to mention program evaluation. While it might be a new skill or a new activity for a lot of outreach workers, we found it at NHF to be extremely helpful to actually bring our promotors into the evaluation process to see if the program was impactful. So I know, Commissioner Champa, you were asking her about outcomes. I will share some in a bit, but just for an example, before I brought the promotors in to talk about evaluation, I was thinking we were going to use a 10 question or more, like 11 question survey for individuals to gauge food insecurity and to see how we were impacting these families and households. And to make it validated, to really show if we were having an impact, it had to be done at initial contact, the first time they met with somebody, within 1 month, at 6 months, and within 1 year. And within the first pilot of the 6th month, the promoters came back and were like, we can't do that. Like, it's overwhelming the people we're engaging, and it's taking too much time. And so we went back to the drawing board and brought them in, and was like, what level of evaluation can we do to still get the data, right, that shows we're being impactful, but doesn't impede on your work? And we decided to use the Hunger Vital Signs score, which I'll talk about in the next slide. But if we could go to this one, that'd be great. So some of the outcomes we saw just in 2023, this program has been going since 2018. It started with a pilot of 2 part-time promotores. We're up to 6 promotores now. It's not a pilot anymore, it's a full funded program in our budget for as long as I could see. And it has had some great outcomes. So in 2023, our promoters were able to provide over 2,000 application and program referrals for food insecurity. They enrolled 313 households and provided that 6 month of case management to those individuals and households. It infused over $537,000 of cash through EBT cards into these households. And we saw, as I just mentioned, a significant drop in the Hunger Vital Signs score, which I'll explain quickly. As you can see in the graph, the Hunger Vital Signs score gives individuals when they take the survey, a score of 2, 1, or 0. 2 being they have high food insecurity, and that means they very likely run out of food within the month or run out of money to buy food every month. Or if they get a 1, it means that they sometimes do, or at least they're worried about it. And if they get a 0, they're pretty food secure. They typically don't run out of money for food or run out of food for the month. And as you can see, it's actually, maybe you can, I'm sorry, it's really light, but the initial survey that our promotores do when they make contact for the first time with a household or individual, the score is, I don't have it in front of me, I think it's 1.78.
It is
1.78. Yeah, which means it's almost a 2. So of those 313 households last year, almost all of them had high food insecurity, which means almost all of them ran out of food every month or ran out of money for food. And at the 6-month check-in, which now we only do it every 6 months, not like I mentioned before at that interval, it's at 1.19, which is basically we eradicated food insecurity for these households, or the promotores did. And again, I think it just speaks to the level of service they provide, their ability to connect with individuals and understand their communities. Because CalFresh alone, although it is a great national and state and county program, it won't do that. So that's layering in these other programs that promotores are aware of and able to encourage individuals to take advantage of. So
It's 0.9, 0.19.
0.19, yeah.
Yeah, not 1.9.
Thank you for that. Yes, it's even lower. It's 0.19. It's almost 0.
Just because our entire commission is typed up, and so
Got it.
I want to correct for anybody who's listening out in Los Angeles, or anybody who later on reads our information. So we have the accurate number.
Yes, I appreciate that. And that's it. The next slide is Q&A. So thank you.
Wonderful, great. So in regards to the recuperative care programs, which is very interesting, kind of like SNPs, or how many such programs do you have, and how many beds do you have in all those programs in total?
We currently have 3 facilities. 2 one in the city of LA. It's in Pico Union. We have 1 in Glendale and 1 in Ventura County, and we're actually opening the largest one in the city and the county in a couple months up in Arleta in San Fernando Valley. It'll be 148 beds, and for Pico Union we have 60.
And where is the funding from that coming from?
All of them, or-
Capital. Obviously you have capital expense, and you have
So the capital expense for the new building is from LAHSA. It was awarded through CD6, a home key funnel of funding. But the beds themselves per night in Pico Union, it's through the managed care plans, CalAIM funding. We have a contract with LA Care, HealthNet, all of them in LA County. And then Arleta up in the valley will be, we're still working on that contract, but very likely through LAHSA.
And then in regards to the individuals who are staying there, what's the average time that people stay there?
It depends. It depends on what the health plan approves of, because this is a higher level of care. It is kind of like you said, a SNF. So if once an individual recuperates, they oftentimes are referred to a different level of care, whether that's just regular interim housing, or sometimes they do move into permanent supportive housing if they're here long enough with us. It ranges anywhere from 15 to 90 days typically.
So if you have a patient who is doing really well and prospering, but they have no place to go, do you just let them stay there forever? Or if you can't find permanent housing for them, what do you do?
Well, we have a lot of discharge options. Our last one always is to like a drop-in shelter. People sometimes, if they are at that level, choose to leave and they go reunify with family or friends or into a shelter. But typically it is into a different level of care, whether that's sober living, a SNF, hopefully into permanent supportive housing. Reunification is a big one for us as well with family and friends. We use all the options available to us.
And how many of the patients were originally homeless versus housed when they fall into your process?
Everyone who comes to us is experiencing homelessness. So do you mean before they get into the hospital?
Yeah, yes.
So everyone who comes to us is experiencing homelessness. They're categorized in the HUD categorization of being homeless. But before being hospitalized, I can't say that number off the top of my head. I'd have to look into that.
If you can find that data, that'd be interesting to kind of track that. And then how many total individuals' lives do you impact on an annual basis?
For the organization or recuperative care?
In all the entire organization?
So recuperative care is 1,300 typically in a year. The organization overall, because of our community initiatives, which has a big impact, it's over 10,000.
Okay, and then what's your annual budget?
Just over 14 million.
And most of that money is coming from,
Managed care plans and grants and philanthropy.
and so managed care is payment for service.
Yes.
So either on a monthly basis, capitated, or alternatively.
It's a per bed per night.
It's a per bed per night. So if we separate the two big arms that you're doing, the recuperative care, obviously, I understand how that's getting paid. But what about, what percentage?
Our community initiatives.
Yeah.
That's primarily grants through county and state. So the Department of Public Health, Department of Health Services, and then for this program, we have some grants through LA Care, the California Association of Food Banks, and then we do have a contract with some of the locations where we provide these services, where individuals come to get enrolled into an application, where they pay us. So they'll typically sit at like a community resource center for 8 hours a workday, right? And we will bill that entity for those 8 hours.
So do you have a resource or a development officer who is writing grants and trying to make connection to do that? Or does that fall into your lap or the executive director's lap?
Yes, both. We don't currently have a development director, but we are hiring one. Look at our website if you know anybody. So that would fall currently and for the last couple of years onto my lap.
Okay, excellent. Commissioners, the floor is yours. Commissioner Ho.
Thank you. My question is regarding the recuperative care. So if it's funded by LASA, then are we saying that those who will get that, who will access that service are already in the pool of the HMIS, as opposed to someone who just fell into homelessness and needs that care?
Yes, that would be correct. So, and they are, well, our LIDA facility, the one that's not open yet, it looks like it'll primarily be a LASA contract, and so the referrals will come through LASA, so they'll already be in their system. But that could mean a street outreach worker could do that outreach and put that person into the system, but refer them into our facility. So.
Thank you.
Thanks a lot for the program evaluation section. I really like that kind of stuff. It goes a long way in building a lot of confidence that the program's really being thought through and well run. A number I saw in the presentation is that maybe there's 2,000 applications, but something like 300 houses that have actually had 6 months care. I don't know if those numbers are connected, but is there a retention issue with the program?
No, so not everyone who comes into a scheduled meeting or during outreach needs or wants case management. It's usually the folks or households with the highest need. So sometimes they come in and just ask questions about a CalFresh application, and a promotor will go through it with them, but then they go home and do it and they never reach back out. They don't need to, right? Or they don't qualify for a whole number of reasons, but they still need assistance, and so they will refer them to other programs that will help them, but they're not getting CalFresh case management. So there's a lot of reasons for that. But
I see. Thank you.
Commissioner Kato.
Thank you for your presentation. You identified two areas, Pico Union, South LA, where you have the programs running pretty well. How were those areas initially identified to go into?
yeah, South LA, NHF has been working there before I was at NHF. So to my knowledge, it was a grant from like 14, 15 years ago. To do youth engagement out there, specifically around sexual and reproductive health, with a few of the schools that cater to pregnant or parenting teens. and it just has built up from there. That was a very direct service program, but since, and again, it's just built up to the CalFresh outreach, nutrition classes, the YPAR, the Youth Participatory Research Programs. So it's just been a long time of relationship building. Pico Union was where we actually opened our first recuperative care after, well, actually not our first, but our first big one that was more than like 5 beds. And so when we do community engagement around that facility because we want to be good neighbors as an organization, and we faced some NIMBYism, and we still do, right, when we come in and want to provide a housing facility or a service. And so the community initiative part of that really allows neighbors to see that we're part of the community, and we want them to be involved.
Okay, I'm going to ask you a question, but don't be embarrassed to say no because the majority of people say no. But are you aware that the city of Los Angeles has a plan for a healthy LA?
For what?
A plan for a healthy LA, Los Angeles?
I don't think so. I'm not-
Okay. So this was adapted in 2015. There was like 91 programs. There's one section that talks about food that nourishes the body, soul, and environment. And there are specific programs for exactly what you're doing in this. You know, there doesn't seem to be like any correlation with what the city wants to do. And it's unfortunate, you know, with what you're doing. But yeah, I'd like to put you in contact with, you know, city planning so they can, you know, get a hold of you maybe.
Sure.
And we can correlate that. The city also has updated a health atlas where throughout the 15 council districts, it shows the most impacted areas as far as disadvantages. And I'm sure your Pico Union South LA would overlap with that. But and we have so many good work going on, and you know the city has these plans, but it doesn't seem like the city's aware of it, so we can't really take advantage of promoting it more. But yeah, maybe after the meeting, if you could give me your, was your email on the presentation?
Oh, sorry, it wasn't actually, but I'll
Okay.
give it to you.
Okay, so yeah, I'd like to yeah, connect you with
I
the
think the
people
city
that
clerk
gave
has it.
presentations last month.
Yeah,
Yeah,
city
from City
clerk.
Planning. It was the
Yes.
Environmental Justice Unit, and I'm sure they'd be very interested because it's part. It was adapted. The health element was adapted into the general plan of the city. It's a part of, you know, you're just doing it, but it's part of the plan. So, well, thank you for your presentation.
Yeah, thank you.
The city clerk can get you Commissioner Cotto his email. We have it.
Oh, okay.
It'd be interesting. He asked a very good question. I would say that LASA probably doesn't even know about the 2015 city plan.
Well, the county has their own plan for a healthy county, but I don't think anybody I think the county employees are less aware than the city employees.
The
my
LASA is a combination of both, so it's a combined public entity. So one would think that they would have read the plan that you're referring to as well. I don't know. Any other commissioners with questions for Dr. Lemos, please?
Thank you, Chad, for this great presentation. I'm going to start with a specific question and then go to more generalized questions. I really appreciated this connection that you made with promotores de salud and case management because I, in my own work, have seen how this can be helpful from preventing ER visits to homelessness and how you mentioned CalFresh. So my question is, besides CalFresh, are there any areas that you are thinking about utilizing promotores de salud for case management in your organization or currently use them?
Yeah, we actually don't use them anywhere. We have case managers that within our recuperative care that almost act as social workers. They're not, not all of them are licensed as social workers, but so they kind of bridge, they're an in-between position, I guess. But we don't currently use them anywhere else in the community initiative space. We are exploring Medi-Cal and signing up for health insurance and potentially case managing for that as well. But we are kind of in the same boat, and we're exploring contracts and how to do that because there is money there for that, and we don't want to do it for volunteer. So.
Absolutely, and I definitely do see that, as Alma was saying, about how to embed the promotoras in a more sustainable way, I definitely do see that correlation in being one of the opportunities of really, having them become part of like a permanent workforce in an organization. My second question is both to give you kudos, because I've seen how your community health worker model has just expanded so much from the first time I started working with NHF to now. So this is like a dual question about what has been the key to growing a community health worker model, and also what can help your organization sustain and continue to grow it, which is one of like the underlying questions that I want to keep emphasizing, like how do we help you? How can we advocate for that?
Sure. I think the success, there's so many reasons, I think. I mean, the staff that we have are amazing. They come prepared and trained and advocates in the community, for their community. They honestly do more work than they're paid for, and it's not illegally or anything, but like, they just go above and beyond so much. But I think something I mentioned here, one of the keys was bringing them into that evaluation piece, because now we do have data and we have information to share back to funders that we're being impactful. Although qualitative data is extremely important, the stories and the sharing the successes is important. A lot of times what's missing, I feel like, in these more grassroots, almost like really frontline level programs, is that hard data, and that has been so helpful. We could not only track a family's food insecurity dropping, but how much money they got, an entire year or 6 months. So I would say that's a programmatic thing that really helped. In terms of what we need for support, I think what Commissioner Hisserick, right here, you mentioned bringing promotores into like the police responses, seeing this model as a prevention model in all possibilities, in the police department, in health programs, in housing programs. Like you were asking, we could bring promotores into our housing facilities, but LAHSA doesn't fund promotores. They have very strict requirements around job requirements and experiences. And so, but in reality, they're doing case management and they know how to do it. So yeah, advocating for it, again, embedding them in places where they might not be seen as traditional employees.
Thank you. Definitely data is king, right? Data is so important, and sometimes small organizations don't have the capacity, right? I think that's like a really big gap that I've seen as a trend. My last question is, you serve two of the communities that just have so much inequity and have so much to go forward in terms of really, continuing to serve that community. So some of the ones that were hardest hit from COVID-19 and continue to face the ramifications of that, specifically, with a lot of people being evicted because of the end of the moratorium. So specifically for these two communities that you serve, Pico Union and South LA, what are still some of the key needs that the promotores are seeing in terms of community?
I think it's programs rolling back at this point, and then they're just becoming overwhelmed, like with the influx of individuals coming to them for assistance. The evictions coming up have not been helpful. The rollback of some emergency CalFresh, the PEBT, the summer program, which I know the state announced that they're going to do that over summer now, so that's great. Yeah. But the application process is very difficult for something they don't get that much money for. And so it's a lot of these COVID protections, I think, rolling back recently, and the workforce is not ready for that influx of people. We're not ready for it, but we also don't have funding to bring more people on right now, so yeah.
Thank you.
Any other commissioners? No. Potentially afterwards. Next speaker is Sul Sarani, who's the Director of Community Outreach and Engagement at Cedars-Sinai Health System or Medical Center, as well as Associate Director for Research Center for the Health Equity and Community Outreach and Engagement. Thank you very much for being here.
Thank you so much, and thank you for the opportunity. And again, thank you, Commissioner Lemus, for inviting me to present.
Can you pull your microphone a little closer to you?
Sure.
Because we are being televised.
Okay. Can you hear me now?
You should just pull it towards you. It'll come to you.
Sorry.
There you go.
There we go.
Wow, so much better.
Okay, so next slide, please. So I just want to start with a little bit of data, and I'm sorry to bore you, but I thought that it was important to set the stage to show, you know, because different communities experience. So I'm going to talk about cancer prevention and control and how promotoras have impacted, you know, early detection in our work with the community in different geographic areas. So in terms of cancer, we see different rates in different populations. And so I just wanted to kind of go over a little bit of that, given the diversity we see in LA. And so, you know, we have obviously the largest in terms of Hispanic Latinos. We have 48.7% of the population. And then in terms of the Asian community, we have two of the three largest Asian communities are Filipino and Korean, and both communities have cancer disparities. We also have the second largest LGBTQ plus population in LA County, and a third of our population is foreign born. And so, you know, and so the next slide, and we also mapped where these populations live so that we're able to really target our work in different neighborhoods based on the disparity we see with a particular population. I'll talk a little bit about the cancer data. So the next slide just shows the numbers, and I want to point out that there's an error there because it's 5 million, close to 4.9 million Hispanic Latinos and not 645,000, so I apologize. So it's the same slide, but it just kind of shows the number of people that we're serving in LA County from different racial and ethnic groups that have cancer disparities. The next slide is, you know, really showing the mortality rates, the death rates for cancer, the different types of cancer sites by populations. And so, for example, the Latinx and Korean populations have the highest mortality rates of liver cancer. And then colorectal cancer and lung cancer are a priority for Koreans who are experiencing high mortality rates. And for Filipinos, you see prostate cancer, lung cancer as a priority where high mortality rates exist. And then, you know, on the next slide, I wanted to also share the variability in cancer screening rates. So the earlier we detect cancer, the better the outcomes are for individuals. And so when we look at the screening rates, for example, let's take mammography, we see the lowest screening rates amongst Korean women in LA County, followed by Filipino, and then the other groups like the Latinx community and LGBT, which we don't have very good data in this population. And even, for example, with prostate cancer, we see extremely low rates of prostate cancer screening in Filipinos and Koreans. And then I also want to go on to the next slide to show that we started looking at cancer data and we started mapping it, using geospatial mapping, and we discovered hotspots all throughout Los Angeles County. But, you know, the brightest hotspot for example, breast cancer was in Koreatown in Pico Westlake neighborhood of Los Angeles. And it's probably because of the sheer size of the population there, but at the same time, you know, when you start looking at that, you want to design and create interventions that actually can work.
So that's
Now-
not per capita, that's just by,
Right, yeah.
right, so
By
it's-
Geography.
right,
yeah.
unfortunately, those two neighborhoods are the two most dense.
Exactly, because we were thinking, how do we prioritize our work, you know? And then we also said, well, maybe there's not enough free or low-cost clinics in that area, but we started mapping, the green dots are the clinics, and discovered a lot of clinics in Pico Westlake area that provide free or low-cost breast cancer screening, which is the Every Woman Counts program funded by the state of California. And then we looked at the same data, next slide please, amongst Koreans, and we started mapping late-stage breast cancer diagnosis because of the low rates of breast cancer screening amongst Koreans that we see. And again, discovered, obviously, where Koreans live, we see the hotspots, Koreatown and other parts of LA County. But we also, again, realized that there's tremendous community assets in these areas. Like there's churches and community organizations and clinics. And how do we connect the dots for community members who aren't getting screened, who are not getting timely screening, or left behind? And so we started looking at potential interventions. Next slide. And a lot of the evidence points to, community health workers. There's like decades of research that is now recommended by the CDC as an evidence-based practice to use community health workers for cancer screening, especially for breast, cervical, colorectal. There's tremendous evidence. And so these are strategies that, we definitely started thinking about. And started working with community organizations in these different neighborhoods. And, that's how I met Dr. Lemus, is through Clínica Monseñor Oscar Romero, where we then funded and worked with a group of promotoras. And we've also worked with Visión y Compromiso. But in this particular neighborhood, it was with the promotoras at Clínica Monseñor Oscar Romero, who are incredibly experienced, very knowledgeable of the community, and new people in that neighborhood, a neighborhood of high need, a neighborhood where you see cancer-related disparities, and so we actually trained promotoras using a curriculum that we developed that was originally developed by the Fred Hutch Cancer Center. We adapted it for Los Angeles and for our communities in LA. It was originally developed for American Indians. On the next slide, I wanted to also mention that in the same area in Koreatown, the next slide please, we started looking at the low breast cancer screening rates amongst Koreans, and also started recruiting volunteers from churches who we trained as community health workers, because we felt that churches are a place of acculturation, a place of resources, a place of knowledge for the Korean community. We discovered in the literature that 70% of Koreans go to church regularly. So this was an opportunity to create an impact. And so we partnered with several churches in Koreatown as well to train community health workers there. And just on the next slide, we culturally tailored our curriculum into different languages for populations that have cancer disparities into Tagalog, Spanish, and Korean. And our staff that speaks these different languages implemented a train-the-trainer model in the training programs. And so on the next slide, wanted to share that we trained 42 community health workers and navigators, and provided funding for both in the Latinx community and the Korean community. And these were the different roles that they played in terms of cancer. They started with cancer education, provided linkages to screening services, and if there was any kind of an abnormal finding, they would support the patient in going to the next level in terms of abnormal follow-up and treatment support. And we also provided information on new research and clinical trials. Next slide. In the Korean community, we implemented our health and faith initiative with Korean promotoras, community health workers. Sorry, there's animation on this slide, so if you could click on the second one.
I think we
And
have.
the impact has been incredible. I mean, the number of cancers we were able to find in terms of early detection, and for the first time ever, materials translated in different languages to impact these communities that are marginalized, that are most affected by have a higher cancer burden. On the next slide, and then we were fortunate to receive funding to conduct a research study testing church-based promotora model in the Korean community, which was never done before, and involving 16 churches. And this approach was to identify women who are not compliant to cancer screening recommendations. So these were women who had never had screening or were not compliant. So the compliance with the use of navigators went from 0 to 68%. And so we started implementing this church by church, and it's had a huge impact. The study is still ongoing, and hopefully we'll be able to publish the results next year when the study is over. But it's showing tremendous promise. And in Los Angeles, we know that there's over 300 Korean churches. So the potential for this is huge to spread this throughout the city to impact cancer disparities that we see in this population. On the next slide, which also has a lot of animation, I apologize. Thank you. Just working with promotoras at FQHCs had a huge impact. So when you look at the bottom line where we see impact, one of the clinics, 85% of the patients returned their fit kits because of the Promotora community health worker intervention. Same thing with Southside Coalition that had lower colorectal cancer screening rates in South LA. Just the navigator intervention changed that in terms of return rates. Clinica Monsignor Romero, when we looked at data 4 years, it was a 4-fold increase in mammography screening through in-reach and outreach just by working with promotoras. So there's, just a tremendous impact in terms of cancer screening. And so just as a quick example on the next slide, we've trained about 40 promotoras who have continued to do this work in different neighborhoods and have reached hundreds of individuals. And let's see, next slide. I have some stories and quotes from the community that I'll let you read. The next slide, please. Yeah, so here's a story. Again, individuals from the community, this is qualitative data. People, basically said they wouldn't have come in if the promoter didn't care for me, didn't call me, didn't, keep informing me about, getting that mammogram. Same, and we see this time and again. Next slide, please. Yeah, in the Pico Westlake area with Clinica Monsignor Romero, again, promotoras had a huge impact in terms of conducting workshops and reaching community members with cancer information. Next slide, please. We work with promotoras to organize mobile screening events in the Pico Westlake area. And, just through a series of grants over 3 years, they were able to refer 811 patients for mammography screening. So, again, it had a huge impact. Next slide, please. And so just, again, I want to mention how grateful I am to the promotoras of Clinica Monsignor Oscar Romero, who are amazing, and our staff who work with them, day in and day out to improve cancer screening. So I want to end by just posing another challenge that we are faced with, and to see how we can receive support from different partners and community organizations, and possibly even this commission. On the next slide. So, we started, again, we use GIS mapping for cancer data in LA County, and we have started discovering high lung cancer mortality in different parts of the city. And so when you layer that with high smoking prevalence, these are extremely high-risk neighborhoods that we really should be screening for lung cancer screening. But California has the second lowest lung cancer screening rates in the country. And, you know, it's just really shocking to see that we've made so much progress in tobacco control, but in terms of lung cancer screening, we're incredibly behind. So while Cedars is investing in a mobile unit to purchase one so we could take it to these neighborhoods, we still need, you know, individuals on the ground, navigators who can connect the dots for people who are eligible for screening and get them in for timely screening, because that's what's going to impact death rates in Los Angeles. So I want to end with that, and I just want to thank you for this opportunity, and I'm happy to take questions.
Wonderful. Thank you for an excellent presentation. It's interesting, just 50% of the lung cancers in women are non-smokers and women who have never smoked. So, you know, it's quite significant. So there's a sexual variation in addition to the racial differences. Separate from lung cancer, we're clearly, you know, smoking has a big impact, unfortunately. Breast cancer, ovarian cancer, cervical cancer is all significantly higher. When you were looking at all those curves and geographic regions that you were showing, is that controlled for by, you know, zip code with percentages of smokers, or do you not have that data?
I don't have that data. It was really done by an epidemiologist, and she was looking at census tracts. So she actually used census tracts to map and you know, the California Cancer Registry collects cancer data by zip codes. So that is really how, sorry, by census tract. So that's really how zip codes, and she mapped it onto census tracts. So that's how she did it.
Yeah, it'd be interesting to control it for both smoking in those census
Yeah,
tracts,
absolutely.
as well as control it for density, because, you know, it's a lot easier to have 10 incident cases if you have 100,000 people living in a small community. You know, if you're in a rural part of the state and there's only 10 people in the county, probably not going to have 10 cancers unless there's some other impact on
Right,
that. But,
right.
and then in regards to Koreatown, there are two hospitals in the last several years that have closed in close proximity to Koreatown, Olympia and unfortunately, both Olympia and St. Vincent's, which is going to have an impact on Koreatown's access to health care. Has those closure of those hospitals had an impact on, you know, the ability to get testing for the men and women in Koreatown?
Well, so in terms of early detection, we primarily work with FQHCs. So because, again, you know, those are the groups that are trusted by the community, that's where they start. And through mobile mammography, through referrals to local radiology facilities, we're able to get a lot of the screening done, as you see with our data. But obviously, yeah, there is a huge impact in terms of cancer diagnosis, cancer treatment, and I'm sure that other hospitals are experiencing the higher load because of that. But again, you know, we work with networks that are already established so that we're able to make sure that it's a seamless system of care for individuals, and that the promotoras provide the support that's needed for people to go from one level to the next.
And we know that Cedars does a lot of great things in the community and a lot of things for outreach and as well as pro bono work. Are these mobile mammogram or other mobile outreach programs that you have, are those billing the FQHCs, or is it done for community outreach in general?
So the mobile mammography is generally through the Every Woman Counts program. It primarily is for women who are uninsured, but they're also able to bill Medi-Cal, but they really work with the FQHC. So the FQHC is able to bill for the breast exam, and then the mobile unit is able to bill for the radiology piece of it, and it's a separate company coming together. So a lot of our work is bringing partners together to make stuff like this happen.
So it's not a Cedars mobile unit,
No,
it's a
not a Cedars.
subcontractor who's
Exactly.
billing
It
for
is-
service, fee for service, billing
Exactly.
Medi-Cal or some
Yeah.
state governmental program.
But yeah, absolutely. However, these are different systems that the patient has to go through, and I think that makes it very fragmented for them, and hence, promotoras and other community health workers, navigators are essential to help people move through these different systems.
And then obviously you're picking up cancers, which is a wonderful thing, especially if it's early
Yeah.
diagnosis. Do you then facilitate those patients getting in through their health system or through into a hospital or getting providers? I mean, the waiting list for some Medi-Cal surgeons, depending in what part of the city of Los Angeles, is dramatic, and there's a shortage of physicians who take Medi-Cal. And so sometimes for some things, even with a known cancer diagnosis, there's excessive length of waiting time. How do you deal with that as a problem?
Yeah, a tremendous problem. However, we have 2 dedicated cancer navigators who actually really work with patients to possibly identify other places where they can go in. But again, the policy work, like you were saying, is key. This is how we're able to take data back to the Every Woman Counts program and identify where the bottlenecks are so that they're able to make sure that more providers are brought in to support this. So there are bottlenecks, and we try our best to support that. But many times it really does take a really knowledgeable navigator to get people to the next level, to get people to other facilities that might be accepting patients.
And so we know that unfortunately a lot of people have very narrow networks of what facilities or what hospitals or what providers they can go to. Would you think, especially given the fact that Cedars or UCLA have teaching programs that have resident-run clinics or fellow-run clinics, that even if somebody was not in those networks, that the state of California or the city of Los Angeles should advocate that people who can't get in within a reasonable period of time with a cancer diagnosis can then open up their network and go elsewhere, say a teaching center like USC, UCLA, or Cedars-Sinai, with some of the finest surgeons in the country.
Yeah, I mean, we accept the Every Woman Counts program for diagnosis and treatment. The thing, though, is that a lot of patients do not want to be uprooted from their neighborhoods. And so while we're able to support people in their treatment journey, and those who are able to come to Cedars-Sinai, we're able to care for them. But again, we need, better solutions in different neighborhoods so that, and yeah, absolutely, I think advocacy is key, and I'm happy to support, any kind of advocacy effort on behalf of patients who are not able to get in.
Excellent, thank you. Commissioners. Commissioner Hisserick.
Yes, thank you for your presentation. You made mention of the Filipino community, but are there any special programs? I didn't see any, maybe I missed it, for the Filipino community, a community that, frankly, we often overlook in assessing the ethnic composition of Los Angeles County, but I think it's one of the largest Filipino communities outside of the Philippines, to tell you the truth. I just wondered if there's any comparable to the Promotores type programs in the Filipino community.
Yeah, so thank you for bringing that up. In the Filipino community, we discovered lower colorectal cancer screening rates, and so we created a program called Be Your Own Fan, which builds on on cultural symbols that Filipinos have with fans and other things that are used in the community. And that campaign, we are rolling it out through a research umbrella to test it specifically. But you bring up a good point. So the Promotora model is adaptable to any culture and community, is what we're discovering. So, like we did in the Korean community, there's absolute plans for us to adapt it for the Filipino community, because there's so many individuals who are in the health field who are Filipino descent that can support something like this. And so we've been building a network of churches through which we would deliver this service, but we've been testing this, this campaign, Be Your Own Fan, in different community settings just to get data on its effectiveness. We're very fortunate also to get the support of the Philippine Consulate, and we're working closely with them and a multitude of organizations that reach the Filipino community. We do have 2 of our staff that are Filipino, and really trying to push the research agenda with this population, because again, they're often overlooked, and there's this perception that Filipinos are in healthcare, so they must be healthy, and that's just not true. And we saw that with COVID and other issues. So, thank you.
Thank you.
Any of the commissioners? Commissioner Picard?
I have a question. The data is great of how successful the promoters have been at increasing the screening. That's like wonderful to see. But going back to the relationship between the screening and the mortality outcomes, I was noticing in the table you have 3 categories: Hispanic, Latinx, Black, and non-white, non-Hispanic whites, where they have 80% compliance, but their mortality rates are still very high. Whereas the Korean population we're focusing on today, they have half that in compliance, but their rates are not one of the higher mortality cancers. What can you provide any insights on that disparity?
Sorry, can you repeat the last part? I'm just going to pull up the data.
Oh, just was highlighting that when we were talking about those first 3 categories where they have high compliance but still very high mortality rates, the population we're focused on today, the Korean population, they have around 48% compliance, which was low and is being improved, but their mortality rates weren't that high, not as high as the other 3 categories. And I was wondering, the disparity between people being screened and the actual improvement of mortality rate outcomes. Does that go back to the fact that those people just aren't able to get care, what we were discussing earlier, or is there something else there?
Yeah, I think it's going to take years for us to see the mortality rates go down, right? Even though, we're, so we also commissioned the California Health Interview Survey to look at the rates of screening in different populations. And so while we got a lot of this data came from the California Health Interview Survey, it's going to take us looking at it in its next cycle to see what type of impact a lot of these interventions are happening at the community level. And to see even a dent in mortality is going to take years. It just of us doing this kind of work. So that's why we're really focused on evidence-based interventions, like what we're doing in the Korean community, where we're able to really look at the impact and use that approach and model and scale it up so that we're able to have a bigger impact on mortality. And again, we're just scratching the surface. When you think about lung cancer and you see the magnitude of the problem, and I know a lot of it is because of the EGFR mutation with women and Asian women, but again, when we look at all the screenable cancers, we're just not seeing the rates there for many of these populations, and we have a long ways to go. So,
I understand, that makes sense. Follow up on the topic you just brought up there. In terms of being lung cancer screening, we're saying, LA in general has a very low rate. It's interesting because I've never, of all the things that my doctor is telling me to be screened for, lung cancer isn't one of those things. And I was wondering, is that an overall oversight that we're just not recommending it enough to people?
yeah, I think, so there's no, for example, HEDIS measures for lung cancer screening, so maybe physicians are not incentivized to, promote lung cancer screening. And these are all theories, we just can't prove it. But again, we also know that at the community level, there isn't consumer demand as much for it. And people forget, because it's based on pack years of smoking, so people forget how much they smoked way back when. Maybe they're not disclosing good information to their physician, so the physician's not able to say, okay, now you're eligible. So a lot of problems with the system, a lot of problems at the community level. But again, I feel like, creating community level demand for something can drive, screening rates to become a little bit higher. And of course, we use a multi-level approach where we promote it with physicians, with community clinics. So, it's from all the way from the neighborhood where the promotoras are to the providers, and bring it all together with campaigns and messaging so that we have that impact.
Dr. Chapa, some of that data, unfortunately, it's not causation data, and so there's comorbidities and other social impacts that we're not seeing, or he's not seeing, because he's searching for where the disease is so they can look at it and make an impact. But the reality of it is, if you look at certain demographic groups in Los Angeles, there's age variation, and
Yeah.
the truth of the matter is you can be
Of course.
very aggressive in treating somebody with colon cancer who's 42 years old, and probably get pretty good success. If they're 87, you're going to have a higher mortality. And so there is, with the Korean population, a demographic difference in age. The other cofactor that's a big one is smoking. Obviously, that has an impact. And then other comorbidities in certain populations, including heart disease and diabetes, which is going to also have an impact on mortality. And the other one, from just the unfortunately neighborhood point of view, if you're in South Central, or if you're down by the harbor, there's a lot of pollution and airborne impact there. So that's going to compound lung disease, asthma, therapies, how aggressive one can be with chemotherapeutics and or radiation therapy. So you're going to, have an impact on mortality. We know certain communities have a higher mortality even without the cancer. And then if you throw in a pretty aggressive cancer in that community, they're going to have less success. The data he has is great, but he would probably need, or his research people and epidemiologists would need a lot more money to do a deep dive to look at stuff. We probably should do that. One of the things we've advocated here to the city is to get some research money allocated to us from the city budget. It'd be nice to have a meeting tomorrow with the mayor to try again to advocate so we have some control of some funds so that we can help and partner with other people and join to give them some seed money so we can get some of that information and data. But your point's very well taken, so it's appreciated. But his is more of a epidemiologic search as opposed to impact study.
Thank you for the insight. Yeah, I think that's kind of the root of my initial connection between the mammogram screening and the, potentially not correlating to more improved outcomes for mortality. Granted, we need to see what the current generation's results end up being. It's that I do think it's a lot of overlaying, a lot of complicated interconnectedness between humans and the outcomes of their life. And I think it does need to be just across the board. It's not even just in this room what we're talking about today, a much deeper epidemiological analysis of all the factors to see what the underlying causes really are. So we're focusing on maybe the most impactful routes of prevention and,
You're right.
fixing it. That's all. Thanks.
Yeah. Commissioner Kato.
You're talking about your health and faith initiative, which I think is great. Was that working with the promotores that sort of led you to that, or?
Absolutely. When we started working in the Korean community, we discovered that there were no community health workers there, but there were lots of natural helpers in churches and places. And so we kind of took the Promotora model and adapted it for this population, and that ended up in this research study that we're now evaluating. So early data showing that it is working, and that every church has individuals like this who know the community members, have a relationship, and we can activate them to motivate folks to get into screening. So
Yeah, Dan Buettner wrote a book called The Blue Zone, identifying certain factors that help longevity. It's nutrition, exercise, but networking, family is one big part of that. And, the promotores, you're working with Cedars in cancer, but this could apply to heart disease, diabetes, and really help do that screening at the early stage.
Absolutely.
So we don't see the disaster like when Corona comes, the virus comes, everybody's worse off, right? Well, thank you, promotores, for what you're doing.
Dr. Lemos, did you have a question?
Yeah, I have a couple. Again, thank you as well for your presentation. Following up with Commissioner Cato's question on partnerships, I, have firsthand experience in terms of how you have effectively partnered with community-based organizations, healthcare centers, and also now churches. Are there other partnerships that you're exploring? I'm thinking because as we think about sites of organizing education, I'm thinking about schools, union organizations that are also like sites of organizing. So I'm curious to know if there's other partnerships that you're exploring.
Yeah, absolutely. I mean, all of the above. We definitely want to explore schools. I think it's been difficult in some instances to do research with schools, but I think in terms of providing services, we're able to, we do a lot of physical activity related research, so definitely partnering with schools. But one thing I wanted to mention is that I think we would love to take our work with FQHCs and promotoras and community organizations to the next level by using technology a little bit more effectively, because I think, we're still very grassroots and we do our work, promotoras are amazing, they use social media, there's so many different ways in which outlets that they explore to get the information out, but maybe we could, really work with FQHCs to think about how do you use your EMR more effectively to identify people in need of lung cancer screening or colorectal cancer screening, and how do we then deliver these interventions remotely to people in these neighborhoods so that they're able to come in even a little bit much more faster. We do have to go out there, as you know, promoters have to go out there and bring people in to the clinic, so we've got to figure out how to use technology a little bit more effectively to reach people where they are and get them scheduled. So yeah, but we would love to explore, unions and schools as well. So
Thank you for mentioning that. I going back to COVID, I think that was one of the biggest gaps that we saw with the promotoras, how they're traditionally seen as outside of the health, specifically for community health centers, like outside. And we saw that technology was a big gap for them in terms of quote unquote soft skills to hard skills. And while I was at the Clínica Romero, that was one of the things that we were exploring, like being able to train the promotoras to be, on OCHIN and EPIC, and being able to transfer those skills inside the clinic. So thank you for mentioning that. Now, my second question is on the disaggregation of data. I really liked that, specifically when we saw the data on cancer mortality rates, that it was broken down specifically for the Asian community between Filipinos and Koreans. My question is, do you see that same need with the Hispanic and Latinx community, specifically as a Central American and having one of the largest populations of Central Americans outside of the region itself? Do you see a need for the disaggregation of data between, Mexican communities, Central American communities, and others?
yeah, because what happened is when we implemented our community health in Los Angeles survey in the Latinx community, we saw differences in terms of cancer screening, behavioral risk factors. And so our sample size wasn't big enough for us to, make these big conclusions. But again, we really need to figure out how to, because there's very little data on cancer screening and behavioral risk factors that's disaggregated in this city. The LA Health Survey is somewhat, useful, but it doesn't break it down even more like you're suggesting. And like we discovered the Pacific Islander high mortality rates from COVID only by disaggregating that data, right?
Yeah.
So I think that these differences would be masked otherwise. And so that's really, the person who did all the GIS mapping, that is her philosophy. She just wants to make sure that everything is disaggregated, and that's how we're going to get to the root cause. We're going to get to, what populations are at high need, where should we prioritize. We're doing a lot of work around making sure we disaggregate. So we're doing a lot of advocacy with the California Cancer Registry to make sure that, for example, sexual and gender minorities are represented in the data because they're invisible. We don't really know what types of cancers affect them. And there's not high quality data for American Indians, for example.
Yeah.
So I think that all of these groups, we really need to focus on making sure that they're visible in the literature and that there's better data.
Thank you. My last question is about funding. And what are some of the additional opportunities or challenges that you see in how to better not only partner with community-based organizations, but also how to better fund them? I know that funding might be limited or in smaller amounts, but what are some of those opportunities?
Yeah, so I actually see this great, the fact that we're mapping, GIS mapping cancer data and looking at neighborhoods of high need, and of course we need to do a deeper dive with the data, but I think that looking at neighborhood level disparities is really where we could really utilize promotoras better, integrate them into local clinics and health systems, and bringing together partnerships around these neighborhoods of high need. So that's the opportunity I see, layering it with technology. I would say that the challenges are again funding. We provide what I'm going to call mini grants to community organizations because they're not adequate and they may not be, there's no sustainability there. So if we are looking at a specific problem and addressing it in a neighborhood, if there is a funding stream for promotoras to affect specific issues like lung cancer in South LA, or looking at where the problem is occurring or specific communities, I think it would have a huge impact. And so really identifying the groups that do this kind of work and figuring out ways to fund them to address specific issues, kind of like what we're already doing, but we still need that funding stream.
Yeah. Thank you.
Any other commissioners have a question? I'm seeing none. Last but not least, Maybelle Payne is the president of Veritas Consulting. You're going to talk about green technology in disadvantaged communities. The floor is yours.
All right, I will now. That's right. Thank you. Okay, so thank you all. Thank you, Commissioner Lemus, for this teeing up. What I want to mention is that clean energy is a new, but not necessarily a totally new frontier in bringing promotoras as a model to deliver key messages and equipment to low-income communities. And so this presentation goes into that detail. And hopefully I'm getting close enough to the microphone. So next slide, please. So the next slide, when we get to it, I want to personify who I am, because at the end, I am from the Pico Union community. I grew up there. I have spent my whole career in the energy industry working with utilities on their utility programs. So I'm a bit of an energy nerd. I didn't really know that I was going to go into this field, but I did. And it gives me a very unique perspective of seeing the tremendous advancement, because California is considered a leader in our country in terms of clean energy deployment, penetration, and we're now moving into the area of decarbonization. Our state is fantastic. The city of LA has been fantastic as well. But when you work in it every day, you see the gaps, and absolutely the gap exists in making sure that the benefits of clean energy, even energy efficiency, benefit all communities, including disadvantaged communities. And so from my background, as you can see there, I come with that unique perspective. On to the next slide. So I'm going to focus more on what do we mean by energy equity? So it's saying that, look, we recognize that, for example, in a state like California, we care about clean energy, we care about decarbonization, we put a lot of money behind it, But we need to go further to recognize that that money is not going all the way down to the communities that need it the most, that have been historically marginalized and overburdened by pollution, underinvestment, and lack of access. On to the next slide. And we're seeing the impact, because while there are many polls where people in general say climate change is here, we're seeing the impact. We all see longer duration summers, et cetera, who is being impacted the most? We find that climate change is inequitable because it impacts low-income communities the most. So the picture on the left is San Diego. A low-income community in San Diego got flooded in the most recent rain. And the picture on the right is Pájaro, California, in Monterey County, where there was so much rain, I think this was last winter, it flooded their whole town. On to the next slide. And we all recognize this, but it's always good to see this kind of information. So children, the elderly, low-income households, socially isolated. So these are all, when we say disadvantaged communities, this is who we mean. People who rely on public assistance, people who lack access to air conditioning are disproportionately negatively affected. And you can see there, 8% of low-income household income is spent on energy compared to the general population. There's a 22% temperature difference between a heat island and surrounding areas. And in a previous version of my deck, I had the heat islands in LA, and they're all in the inner city. They're obviously not in more wealthy communities. There is 2 times the heat wave mortality rate. So I should read it exactly just to make sure I have this right. Heat wave mortality rate is nearly twice the average for African Americans living in Los Angeles as compared to the general population. So these facts are here. All these numbers, by the way, are local to either the state of California or to LA. Next slide. And this is also specific to LA. So lack of access to home air conditioning in the LA Long Beach metropolitan area. So 59% of African American households don't have air conditioning, 55% of Latinos, 52% of communities living below the poverty line, whereas the general population, 40%. So the numbers just stand out in regards to disadvantaged communities. On to the next slide. So are there mismatched priorities between what the state of California cares about and what low-income communities care about? So from an energy perspective, because obviously California cares about a lot of things, but here I just took this slice of what we care about. So we care about decarbonizing our economy. We care about energy efficiency. We care about water heating conversion from gas to electric. We care about gas vehicle conversions to electric, or at least non-gas. And here are some basic fundamentals on the low-income community side. We need living wages, health care, affordable and quality housing, and clean air. And so I'm an optimist. I don't see mismatched priorities because there are overlaps, which we'll talk about in a few minutes, where California's focus in these particular areas can also support the needs and wants of low-income communities. But the problem lies in the current strategies and the fact that there are few direct, tangible, immediate-term benefits to low-income communities. So if you're talking decarbonization, it's still too abstract for the most part. But when you distill it down, and there's a lot of energy nerds like myself that can bring it down to specific measures, equipment, where there is a match between both. And when I mention current strategies, I'm specifically referring to community participation is not a current element in traditional energy program design, because at the beginning when we design energy programs, we believe that equipment is king, that if we're able to do some engineers doing calculations on what is the most cost-effective way to decarbonize, or what's the most cost-effective way to bring energy efficiency to the market, there's a formula that is done, and what juts out is equipment. And so, for example, the most cost-effective way to reach our decarbonization goals is through conversion of water heating, from gas water heating to electric. And so if from the top down, you say that's the way we're going to do it, then you're just trying to push it down the channels to people. But the problem is that nobody's asking the community, well, will an electric heat pump water heater make your life better? It'll make our state's decarbonization goals reached faster, but nobody's asking the community. And but there's still, again, I'm an optimist. There are decarbonized type equipment that can make a person living in a low-income community their lives better. Either their apartment or house or home is cooler or warmer. The impact of pollutant air coming in to your house can be that you can create better barriers. Or if you are cooking with natural gas in your home, which if you think about it, you're creating combustion in an enclosed area. What if we converted to induction cooking? The air in the home can be cleaner, and maybe if you have people in your home that have asthma or have respiratory issues, there's less combustion in the air. So there are connections, but I think we need to try harder than what do the numbers say, and then just pushing it down. An impact of this strategy of like, let's make the cost effectiveness be the driver as to the measures that get into the community is that there has been almost no emphasis on marketing and outreach, and the integration of the community voice in these programs. On to the next slide. So because I come from an energy background, the good thing is that we do have a good base. So as you see there on the left, there are energy efficiency measures today that have possible health outcomes. And if we emphasized the health benefits, so the co-benefits of clean energy, not just energy efficiency or energy reduction or decarbonization, but rather the health outcomes that me as a resident can possibly benefit from, you've changed the value proposition. Do I really want to help the state of California decarbonize? Maybe, right? But I really would rather help my family today. And these are examples of those. On to the next slide. So this is the convening or the culmination of these different conversations and presentations earlier today. So one thing that Alma had mentioned is these promotoras are embedded, they live in the community. So currently in energy programs, you do have marketing and outreach, but it's a tiny portion of the budget. And you may have outreach workers. You usually have somebody right out of college, usually, and they are given a flyer, like this was one of my first jobs, right, by the way, out of college, and the flyer would say gratis, free, because again, the engineers had figured out what is the most cost-effective measure that we can get out into the community, and I would go out into the communities, but nobody knew who I was. Fine, I spoke Spanish, but so, and why are you giving me something for free? So there's no trust. And so all day long, for decades, we've been running energy programs this way. So, and we've never tried this. So let's bring promotoras as that outreach element by one, educating them, increasing the capacity of energy, because my world is very nerdy, it gets very nuanced. But at the end of the day, there are values and clear benefits today that people in the community can benefit from. And we've never spent the time to just sit down and figure that out. The messaging, find the measures, find how expensive or not expensive it's going to be, but not the how will it benefit. We always talk about in business school, like the value proposition. What is the value proposition of clean energy and decarbonization to low-income communities? Nobody's asked. Next slide. So here's the framework. You start with a trusted community resource. You bring services, offerings, and messaging custom to the community. Key is the listen, learn, and adjust. So there needs to be a certain amount of understanding by the funders, be it the utility, the city, the state, that we may have to change the measures. We may need to change the messaging is easy, and nobody, there's no cost impact, but the measures may be. So instead of electric heat pump water heaters, maybe it's more stoves. And then from there, demonstrate tangible results, because at the end, that's the only way that we're going to actually be able to scale this and make a difference. Next slide. So here is, again, another way of bringing this closer. So tie clean energy and healthcare closer together. There are intrinsic and extrinsic factors, both within healthcare and clean energy, that are tied and can be used to be fundamental elements of a program design. Next slide. There you go, and that's it. I went through it really quickly to show that we're at, I was more about setting up the current problem. Climate change is not equal. There are limits, and there hasn't been enough care in the marketing and outreach, and at the end, what are the right measures that will improve the community today? And we need to design a program, and I think my colleagues here have so much experience. One last note is that PG&E, Pacific Gas and Electric, we presented this idea to them, and they loved it, and they said, we are committed to figuring this out. And my company was the, in a way, negotiator with PG&E, because at the end they still have metrics that they need to give to the California Public Utilities Commission. And at the end, I wanted to make sure that that Visión en Compromiso, there are partners in PG&E, that the promotoras were all going to be paid, that there was enough hours in the budget to do this iterating and these conversations, and that there was enough time to then circle up the data so that we can then change the design, and that there would be commitment from PG&E that they would change the design if we needed to, and there is. So we're trying that out. It's going to start in June. Thank you.
Great. So I think there's probably consensus on the commission that we support what you're doing. There are economic costs, and it's interesting in your beautiful presentation that you didn't mention the costs and where the money is being spent or paid. But unfortunately, decarbonization costs money. Gas versus electric from other sources gas is cheaper per unit therm, and so the money has to come from somewhere. And in the lower socioeconomic class, or people who are living even 2 or 3 times poverty level, they don't have you said 8% of their entire budget already is being spent on heating. If that goes to an increase of 20% or 30% above the 8%, they don't have that in their budget. Most of these people don't have $400 in case they blow a tire and need a couple of new tires. And so you're going to have to cost shift that to somewhere else. And the question is where? The city's red ink, so we can't pay for it. If you start charging other individuals to pay much more, and there is some discussions in Sacramento to do that, those people are already paying significantly more in their taxes, and so you're motivating people, if you keep on pushing up the costs on the middle class, the upper middle class, for those people to leave the state of California or leave the city of Los Angeles. Additionally, if you look at renters, significant percentage of population renters, the mom and pop owners can't put new equipment in or recapitalize with a major capital expenditure because of 2 reasons, one of which is because of rent control. They can't put the costs on, so they're barely making profit now, and so then they'll be at a loss, and most business people don't go into business to make loss. Additionally, because of the, I'll use the term loosely, mansion tax, doesn't impact just mansions, but also impacts, you know, mom and pops, duplexes, quadplexes, eightplexes. And so for an individual landowner, mom and pop who has an eightplex, if all of a sudden, you know, they flip their value of their property, if they put $400,000 in, it helps the environment, then all of a sudden their property is worth, I'm making it up, 5.2 million as opposed to 4.8 million. They're taxed on the whole 5.8 million, even if they sell the place and only have a $300,000 capital gain. They're taxed on the whole thing at 4.5%, which means their investment basically goes to a negative number. People just don't do that. So you're going to end up finding a problem with mom and pops doing that. Or alternatively, mom and pops can sell to Blackstone and to other large, you know, players, and they're looking at a global economy. And as much as they might be pro-carbonization in their documents, truth of the matter is they're looking at what China's doing, and so they say, well, we're going to spend X number of capital dollars, not be able to, because of rent control, push those prices up, and everything we do, as much as it's a good thing for the world, the People's Republic of China is going to just build more coal-fired electric plants, and you know, Blackstone's not in business either to lose money. They're, you know, capitalists. So as much as we might agree with everything you're saying, nothing in your report talks about who's paying for this.
Yeah. So, you know, every day I either wake up optimistic, like we can do this, or not, because of all the problems and challenges. There's challenges every step along the way. But let me mention, because I am in this industry, a few areas that aren't being maximized. One of them is that the investor-owned utilities have low-income programs, energy savings assistance programs. And these are programs that they give away free measures. They have not spent, one utility in particular that I'm not going to mention, had only spent 40% of their budget, 40. And the money just sits there for whatever reason. So the money exists, number one. Number two, each utility takes from our utility bills a public benefit surcharge. So the money exists. And there are layers to this. So starting in energy efficiency, there's an overlap between energy efficiency and decarbonization in terms of measures. The tax, the property value, I would say that there's the tax implications, but first, because we're trying to move the market, literally trying to move, or figuratively move mountains, in that 95% of water heating in California is gas. What percentage can we turn to electric to meet our energy decarbonization goals? There are a lot of carrots, more so than laws. So carrots being incentives, and very, very few cities are saying we're going to force the conversion of gas to electric. But those are our two tools. We either have carrots or we have sticks. So it's either incentives or codes. And right now, everything's more on the incentive side. Now, if a property owner decides to take advantage of the incentives for their 5-unit, 10-unit, et cetera, apartment building, and they're right at that point of value and they want to sell, I don't have an answer for that. But I do absolutely care about the mom and pops, and to what degree are they keeping the property because it's important to them and they believe in rent control, and there's pride in keeping the quality of their housing intact. There are some, but I agree with you, not everybody, and at a certain point you may need to sell, and you sell to Blackstone, and I don't have an answer for that. But I think there is value in taking advantage of incentives that exist, but at the end figuring out how does it benefit low-income communities, and nobody's asking that.
What I would say is if you can convince the people who wrote the proposition to have exceptions and/or alternatively, anybody who does your decarbonization, as you've suggested, has that tax waived, then all the mom and pops are going to start pouring tons of money into it, and then you have a creative way to get people away from doing that, in which case then they'll hold the properties and/or they'll sell it to other mom and pops. And that, I mean, that'd be a way to do it. I'm not convinced that you can get the writers of that proposition to do that, or alternatively, have the tax on gain and not the total dollar amount, which is just, you know, bad legislation, which goes against everything we're trying to do for a green economy. I mean,
And if
it's
that's the thing, I'd love to support whoever can do that. I don't know that world, but I'm an energy expert that can pull the data to support something like that if anybody's interested.
Commissioners. Dr. Chavez.
I really like the slide you have here about the mismatched priorities. I think that's like a great idea, and the fact that there's already programs and money in place from not just California, but the federal government for energy efficiencies and energy improvement. And we were just talking about focus on funding, but I like your line here about it's the current strategies that might be the problem, because we have aligned goals, we're just not going there in a way that's equitable for everybody. And my question would be, I haven't seen how all of those are written, but have we maximized the interpretation of those words to see if there's other ways of implementing strategies that aren't the direct implied strategy?
Our state has absolutely said the decarbonization of water heating is the #1 strategy. It's the #1 most cost-effective strategy. And there are really good initiatives that are pushing towards that. There's also a market for it. So it's not like this is what the state of California is saying and we hear crickets. In fact, there's a statewide incentive program called Tech Clean California. They have incentives, and they very often run out of the rebates. But it's all from general population residents who need that tipping point, that extra rebate. Think of, you know, when you go to, you go to an appliance store and you may see the Energy Star little tag. In the past, there was like a $50 rebate for Energy Star high efficiency refrigerator, et cetera. $50 really isn't going to make a huge difference in your cost, probably less than your taxes, but it's that extra incentive. But that's for the general population. So those folks who today are saying, okay, the state of California is supportive of electric heat pump water heating, here are the incentives, I'm going to take advantage of the incentives, it's everybody but the low-income communities. And so we go back to, we have decades of advancement in energy efficiency all by the middle class and above, which is fine for the state, but in terms of real impact to the communities that need it, it really doesn't penetrate.
I see. Thank you.
Commissioner Cotto.
Well, I think the passage of SB 1000, helps your cause because makes each city in their general plan focus on bringing equity to the disadvantaged communities. And because of that passage of that SB 1000, city planning in LA created the Environmental Justice Unit that presented to us last month. And I'd really like to connect all of you because one of the things, there is still a very small unit with maybe 6 staff members, but out of all the areas, they said that, they're going to focus on health, air quality, and open space first. And health with Chad and Zoe's presentation and air quality with yours comes into play. What they're going to be doing is outreach, and I really think they should work with the promoters right now.
Yes.
In this outreach phase.
And to be perfectly fair, outreach, there's 2 models. One of them is a workforce development model. Let's help young people in the community learn about clean energy, and let's give them their first jobs or their first internships or trainings, et cetera. And like me, and they're out there with the flyers or signing people up at different community fairs, et cetera, and that's valuable. At the same time, this adding of promotoras hasn't really been tested. and nobody's really said, like, this is important. Look at all the amazing benefits that have happened on the healthcare side. Why haven't we tried it on the energy side? So far, at least from my, and it's not, factual, like 100%, but just from my observation, the outreach that outreach strategies have been employing workforce development kind of priorities as opposed to, let's say, a promotora model.
Well, you're an optimist, so let's keep our fingers crossed that this unit could work in, doing that promotora model outreach to better penetrate, get the information out to
That
the
would be
community.
fantastic.
Thank you, Mabel, for your presentation. Just following up on your last statement there, do you think that there is like a real reluctance from the energy world to do more of a grassroots approach to marketing and outreach, because it seems that they've been following this particular model, right, workforce? Like, do you think there is a hesitation? Are they afraid of something? Is there something missing besides the promotoras?
Right. I think that the numbers, the goals, like especially when I think of the utilities, it's really the investor-owned utilities. They've been able to meet their energy saving goals year after year. It's really only after George Floyd that everybody across the whole country, and especially in here, not especially, but here also in California, that the California Public Utilities Commission said, wait, we need to do more about equity. We need to do more to really not just say it. We have low-income programs. That from a portfolio perspective, we're checking all the boxes because we're California, of course. But are we really doing it? And so a level down in detail is that the energy efficiency programs are being divided into 3 areas. One of them is, it's all about cost effectiveness. Great. Another one is about market development, market something, and it's more like workforce development, marketing, like things that don't have immediate benefits, they're means to an end. We need to not have a cost effectiveness rule there. That doesn't make sense for workforce development and for marketing. And a third one is equity programs. The idea that a program that is reaching a low-income community should not have to be burdened by how cheaply can you do it. Because when you start doing the numbers, how cheap can you do it? Marketing and outreach is the first one that goes out. So there is, and now, for example, so it took a while, but at least with the investor-owned utilities, there is a carve-out. Here's the amount of money that they have for equity programs, and there are certain criterias and objectives, but cost effectiveness is no longer one of them. So I think I'm an optimistic person, and this just started. In fact, the PG&E program is the first one. It's a residential equity program, and it's going to launch in June.
Fantastic. You mentioned there is a fee that comes out of the utility. Is it public service fee? Okay. Would that public service fee, would that present an opportunity for funding of promotora models? And then if so, who are the partners that you need to do that advocacy? Like, hey, we should channel more of this fee to fund these type of programs.
Sure.
How does that happen?
LEDWP.
Yeah.
And LEDWP has a great precedent. So one example is there's a small business direct install program that Edison, Southern California Edison has. And because their priority is cost effectiveness, it's all about how cheaply can you implement that program. But LEDWP is different. And they said, we have different priorities. It's not just cost effectiveness. What is the cheapest way that we can save a KWH? But rather, how many green jobs can we create? How involved can we have the community? So to me, it's a difference. It's like an A and B scenario. There's Southern California Edison's Small Business Direct Install Program, and then there's LEDWP. And the LEDWP includes union workers. It includes very specific high quality measures like the lighting. These are all in small businesses. And so LEDWP, I think, is really a leader in the way that they've said we have more than one objective. So similarly, I could see something like this following very much in their priorities, which is we're going to use energy to support vibrant communities. At least I see that, and maybe we just need to initiate a conversation.
Thank you.
Any other commissioners? Any other questions for any of our stellar panelists? No.
Just like to
none.
thank everybody for
Well, I just
taking
wanna
this time.
Thank you all
It
for
was
being
very,
here. And I'm also very optimistic, and I quote Shimon Peres, who said that you can be an optimist or you can be a pessimist. It's going to be what it's going to be, so you might as well be an optimist. It's a lot more fun. Having said that, thank you very much for coming. We really appreciate your time, your effort, your wisdom for educating us and the people of Los Angeles. I would say that for those of you that we asked some questions that you didn't have, if you can send that to us, we really appreciate it. We do report to the City Council and to the Mayor on an annual basis. We would include in advocating for what you're doing to the City Council, and with a hope that we can maybe get some funding for some of your groups, because we need to do it, and we actually think that being out in the community is important, and also not-for-profits that are doing it, or even partnering with a for-profit organization in the community is sometimes better than growing a government that has no funds and has a budget that has no ability to expand. So thank you very much. We really appreciate, we respect your time, and we thank you. And then, being that it's almost Valentine's Day, we wish you a happy Valentine's Day to you and all that you love. And we'll move on to our next agenda item. I'm going to go a little out of order. There was a chance for open comment. You guys you're welcome to stay for our regular business, but I also respect your time. You do not have to stay. We will not be insulted. So you're welcome to all leave.
Thank you so much.
Thank
Yeah,
you.
it's great. Great panel.
Thank you.
So I'm going to go a little bit out of order. We previously had a question from public comment. And so, though we've moved on past that, being that Nurse Denitra Thomas has come to the commission, has requested several minutes for public comment. I'll invite Nurse Thomas, who's a LA community nurse, to come up and to give her public comment.
Want me to time it, or you want to just? Good evening, everyone. Can you hear me?
No.
Okay.
Now we can.
Okay.
There
Okay.
we
So, thank you for allowing me to speak on this subject. I originally wanted to address this subject with the Homeless Committee, but I do see that this is also a healthcare issue. So, older adults are the fastest growing age group of those experiencing homelessness, composing nearly half the homeless population, according to an October 2023 Department of Health and Human Service report referenced in an article by Linda Couch, featured on leadingage.org, published November 1st, 2023, citing that the number of older adults experiencing homelessness is expected to triple by 2030. This problem can be addressed with the utilization of resources already available to the population 65 and older, such as Medicare, Social Security, long-term care insurance, retirement, and veteran benefits, making long-term housing available for the growing elderly population will not only grant them quality of life in respect to less quantity, but it can also decrease the cost of Medicare to house them and provide space for rehabilitation and site treatment to the unhoused population who are younger and have a higher probability to re-enter the job market. So there is already a shift in providing care to the unhoused through the health care system that was presented today from the National Health. So however, mixing these populations is unfair to the quality of life that our senior population should be experiencing. This route will improve the lifestyle, longevity, and vitality of the senior population, create jobs, foster relationships between the old and the young by providing a space to properly nurture them in a more desirable environment, and
You can keep on going.
okay, and provide an opportunity to focus on tackling the needs of those experiencing psych diagnosis and drug addiction with specialized staff specifically trained in this area to develop and execute effective care plans.
Fantastic. Thank you so very much for coming down. We truly appreciate
Thank
you giving your voice we invite you to come back as much as you want and attend our meetings and give your opinions to the commission and to the people of Los Angeles. Thank you.
Thank you, guys.
Sorry, you're a nurse?
Yes.
With which affiliation?
I'm an LVN and I work in the community. I've been a nurse for 10 years, so I've been working like in every area with disabled children, elderly adults, hospital liaison, and most recently I'm working with the elderly population in the community doing home visits, and I'm just seeing there's a more, we need to move them out because working in the facility, I see that there's more psych patients coming in and it's making it really hard for the elderly to thrive and to just, they're already having a hard time, but they can have a better lifestyle in a more home type of environment, which a lot of places like hotels, assisted living, things like that can be established to kind of give them their own like privacy, and I feel like they deserve that.
Okay, thank you.
Can we ask questions?
Not supposed to.
Oh,
Oh, sorry.
That's okay. You're such a great commissioner. I wasn't going to cut you off.
talking to me?
But we're limited by the
understand.
Brown Act of what we
Oh.
can do, and so.
Yes, I understand.
but thank-
completely.
and-
I will come back.
Well, you definitely you can come back. And what I would say though is because some of the commissioners actually do have an interest in learning about some of the things you're saying. If you're a presenter, then there can be a give and take. But if you're presenting on public comment because it's not on the agenda and hasn't been notified for 72 hours, we can't really have a give and take. But you could reach out to the city clerk and potentially have a seat at the table, in which case then there can be a greater conversation and discussion.
Thank you. I'll do that.
All right.
Thank you so
All
much.
right, thank you.
That would be great.
And my contact information is on the agenda.
There's your-
Ms. Thomas, the contact information for the city clerk is on the agenda. Yeah.
She has it.
All right, thank you. So moving on to agenda item number 2 is the discussion of the first draft. What I would say, given the late hour, the draft has been sent, I believe, to all the commissioners. I would ask that you go through and highlight, red line, blue line. You can, on an individual basis or in a small group, less than 50% of the commission, either communicate to each other, or you could reach out to the individual research associates. They have broken down the work that they're doing into regions, into blocks. So they can let you know which one of them has written or has coalesced each of the portions of the report. And you can communicate directly to them if you have questions, concerns, things you wanted added, things that you had problems with. And then I think we could, if it's acceptable to the rest of the commission, move on and put this on the agenda for the next meeting, unless somebody wants to bring up something specific that bothers them now. All right, seeing none, I think there's consensus there. So items for future discussion, anybody want to, please?
If I may, I asked Rita to include this in everybody's packet. It just came out today. The county health department is establishing community public health teams in 10 locations within the city and the adjacent parts of the county. I thought this might be a topic for future discussion. It seems right on point for some of the things we're concerned about, although it doesn't make it very clear exactly what they're going to do. So maybe we could get in at the beginning to learn a little bit about what it consists of.
Is there, in that flyer, is there a point person or
I
communication?
looked through it. No, it doesn't. I didn't find a name. It just came out as a news release. Maybe the
If
young
we could,
folks can find it, or
if the city clerk can speak to the county's communications people and find out who the leadership of this group would be, it'd be nice to have maybe their communications officer and/or their director come to talk to us. That'd be wonderful.
Yeah,
I think that'd be
Yeah,
great.
just looking at this, there's one, it says neighborhood in Boyle Heights. The community-based organization is, we had the presentation today, Visión y Compromiso. So, on this. So, maybe instead, this is countywide, but Boyle Heights is the city of Los Angeles.
right.
And they want to work with White
Pacoima
Memorial.
is, and Wilmington, and some of the others are right immediately adjacent to the city of LA, so obviously there's
Yeah, okay.
overlap.
All right.
So anyway, I just thought it would, seemed on point. Excuse me.
Oh, wow.
And any other ideas that you have, you're always welcome to email me or the research associates. Commissioner Ho.
Thank you, Mr. President. I want to take a few minutes. I'm very cognizant of the late time, but I do want to take a few minutes to bring back what I brought up at the last January meeting about the about that motion that was presented at City Council. At the time, I did not have all the information with me, so I was a little discombobulated, but with the benefit of time, I went to read everything, and it was suggested at the last meeting that we should not address it because it was included in meaning the Housing Homelessness Incentive Program, HIP for short, was addressed in the annual report, but it wasn't. So because time of the essence, I would like to ask if the Commission and you, Mr. President, if you would consider having to allot like 10, 15 minutes at the next meeting to hear from someone from the managed care plans to talk about this initiative, since time is of the essence. It seems that reading the motion, the city would like to explore programs that might be available for the city to implement to address the homelessness. The funds are there, the programs are not there. So I think,
Yeah, if you can get us the names of people who are knowledgeable for those programs, they're, same thing. You can invite them. I think we've talked about this beforehand. You're welcome to invite them yourself independently, or you can ask one of the research associates if you want them to be your go-between to reach out to the people. You just have to give them the names and contact information, and on behalf of the commission, you can invite them to speak. And right now, the March agenda has not been set.
sounds good. I will contact the CLA's office since they seem to be the one who are in contact with the MCPs who administer this program. So as I find out more, I will email you and Ms. Moreno as well
Yes.
and give you the details.
Fine, that works.
But thank you for your consideration.
Yeah, that's good. Any other? No? Seeing none, is there a motion for adjournment? Have a happy Valentine's Day to all of you and all those that you love. Is there a motion for adjournment? All in favor of adjournment? Anybody opposed? It's unanimous.